Hey guys, welcome back to my channel, The ENT Resident. Today we'll be picking up a topic that is a little bit difficult to understand. So we'll start a series on rhinoplasty today. But before we start talking about rhinoplasty, we need to know the surgical anatomy of the nose, which is important in relation to rhinoplasty. You need to know the proper surgical anatomy, especially of the external nose, if you want to learn about rhinoplasty. So today we'll be discussing about the surgical anatomy of the nose. We'll discuss about certain triangles. We'll discuss about certain important terms used in this portion. You can also now purchase my notes. I have added links in the description. Okay, so let's get started. So we'll be talking about mostly the external nose. I already have a video on external nose anatomy, but this will be going more in depth in with respect to rhinoplasty. So external nose, we can divide it anatomically into three parts. Here you can see, here would be the bony pyramid. Below that is the upper cartilaginous vault, and below that is the lower cartilaginous vault. So we have three parts of the external nose. We'll be discussing each one of them in details now. So starting with the bony pyramid. Now what is the bony pyramid formed by? So the structures which is forming the bony pyramid is, first of all, we have the paired nasal bones. So if you look at the image over here, these are the two paired nasal bones that we have. Next, the second thing we have is the frontal process. This is the nasal bone, and this is the frontal process of the maxilla. So this is the second, which is there on both the sides. This is our second part of the bony pyramid. And the third part is the nasal part of the frontal bone. You can see in this portion over here, the nasal part of the frontal bone. These three things together are forming the bony vault or the bony pyramid. Now we'll talk about the nasal bone because that's very important over here. All the osteotomies that are performed on the nasal bone. So it is important to know what are the articulations of the nasal bone with the surrounding structures. So let's start with medially. So as you can see medially here, these are the two nasal bones. So medially, you can see that the nasal bone is articulating with each other in the midline along the dorsum of the nose. And these nasal bones, what they do is they combine together to form a crest. So if you look over here, this is the crest of the nasal bone. This is a sagittal section that is showing the bony structures. So this is a crest of the nasal bone which is formed in the midline where they are meeting. Now this crest of the nasal bone is now articulating superiorly with the nasal spine of the frontal bone and with the perpendicular plate of the ethmoid, as you can see over here. So the red structure is the crest of the nasal bone, the blue one is the nasal spine of the frontal bone, and yellow one is the perpendicular plate of ethmoid. So you can see how the nasal bone crest is contributing to forming a part, a very minor part of the bony septum. So medially, we have the nasal bones articulating with each other in the midline, and they meet each other in the midline to form the crest of nasal bone. And this crest of nasal bone articulates with the nasal spine of the frontal bone superiorly and with the perpendicular plate of ethmoid. So this is our medial articulation. Now looking at superior articulation, superiorly we have the nasal bones articulating with the nasal process of the frontal bone. This will be the nasal process of the frontal bone, which extends downwards deep to the upper end of the nasal bones and the frontal processes of maxilla. So this portion, it actually goes downwards deep to this is the upper end of the nasal bones. So if you see the boundary over here, this is the upper end of the nasal bones. It goes deep to this area and provides a strong support. So that is a superior articulation. Next, coming to lateral articulation, if we look over here, this is our nasal bone over here. Laterally, we can see that it is articulating with the frontal process of the maxilla by the nasomaxillary suture. So this is our nasomaxillary suture. And the frontal process of the maxilla is extending from the piriform aperture to the anterior lacrimal crest. And then it unites with the frontal bone by the help of the frontal maxillary suture. And a very important point to know over here is that this frontal process of maxilla that you see over here, it is thicker below and thinner above. So that's a lateral articulation of the nasal bone. Lastly, coming to posterior-inferior articulation, the if you see the image over here, let's look over here. This is the upper lateral cartilage, as you can see. So the posterior inferior articulation, you can see that this is a cephalic border of the upper lateral cartilage. This border is attached to the undersurface of the beveled lower edge of the nasal bone. Now each nasal bone, it gets tapered, thin and beveled below. But at the upper part, it gradually thickens upwards, encroaching upon the nasal cavity. So inferiorly, it has an articulation with the upper lateral cartilage cephalic border. So these are the different articulations of the nasal bone. So if we had to revise once again, if we look at the image over here, we have the two nasal bones over here. Medially, they meet each other in the midline. Then they form a nasal crest of the nasal bone. Now, this crest of the nasal bone is formed in the midline, and then this articulates superiorly with the nasal spine of the frontal bone as well as the perpendicular plate of ethmoid. And it is giving a slight contribution, very minor contribution to the bony septum. Next, we have superiorly, as you can see, it is forming an articulation with the nasal process of the frontal bone. Then laterally, we have its articulation with the frontal process of the maxilla. And this line that we see over here, this is the frontomaxillary, the nasomaxillary suture. And then posterior-inferiorly, we have the upper lateral cartilage encroaching upon it. And very important to know is that the nasal bone is thick above and thin below. So these were our articulations of the nasal bone. Now, before we move on to discuss about the upper cartilaginous vault, we'll also discuss a few common terms that is important, and you should be knowing these landmarks, anatomical landmarks, in relation to the bony vault. First, we have the glabella. Now let's look at the image here. This is the glabella. So what is glabella? So if you try to touch your forehead in the midline and you try to come down, you'll see there is the most prominent smooth area that you can feel almost between your eyebrows. That region, which is lying in the midline on the forehead, and this lies at the level of the supraorbital ridges. That point is known as the glabella. So this is our first anatomical landmark. Now, as you trace your finger down further, you will hit a depression when you are rolling a finger down towards the nasal bone. That depression is where the nasion is present. What is nasion? If we look at the image over here, we can see that these are the two nasal bones, right? These two nasal bones are joining together in the midline. So the bony junction where the two nasal bones are meeting up with the frontal bone superiorly. This junction, this point that we are forming over here, this point over here is corresponding to the frontonasal suture, and that particular midpoint of the junction is known as nasio. So when you roll your finger down from the glabella towards the nasal bone, the first depression that you hit is the nasion. So this is about nasion. And the third point that we need to know is the rhinion. If you look at the nasal bones again over here, they meet in the midline, and there is the lowermost point where they meet in the midline. That lower end of this suture that is being formed between the nasal bones is known as the rhinion. So we have the glabella, which is the most prominent, smooth, prominent part on the forehead at the level of the supraorbital ridge. Then we have the nasion, which is the depression when you roll down your fingers further. This is the bony junction between the two nasal bones and the frontal bone, and Rhinion, which is the lower end of the suture found between the nasal bones. These three are very important points that you need to be able to identify when you are doing a surgery. Now, there are some other terms that you need to know, like radix nasi. What is radix nasi? So, radix nasi is this upper part of the nose, which is formed by the articulation of the nasal bones and the frontal process of the maxilla with the nasal spine of the frontal bone. So, this is what the radix looks like. Then we have the dorsum nasi or the dorsum of the nose. Dorsum of the nose is basically the ventral aspect of the nose which extends from the nasion to the tip of the nose. This whole region would be the dorsum of the nose. Then we have the nasal bridge. Nasal bridge is the bony part of the dorsum nasi. The bony part of the dorsum of the nose is known as the nasal bridge. Lastly, we have the nasofrontal angle. If you look at the image here, we have two lines over here. The first line is passing along the dorsum of the nose, and the second line is passing along the glabellar part of the forehead. Now, the angle formed between these two lines is what is known as the nasofrontal angle. And normally, this is about 125 degrees in a normal person. So these are all the terms that you need to know in relation to the bony vault of the nose. Lastly, let's talk a little bit about applied importance here. Now, the nasal bones, they can either be symmetrical, but you can even find asymmetry in the nasal bone. And sometimes even there can be absence of a nasal bone, which is known as agenesis of one or even both nasal bones. Sometimes the nasal bones can be markedly large in size. So these are all things that can be anatomical variations that you may come across. Second is when we'll talk about osteotomies later in a video when I discuss about rhinoplasty procedure. When you're performing lateral osteotomy, this should not extend right up to the upper thickened end of the nasal bone at the level of the nasion, because at this level the nasal bones cannot be compressed further because the bone is very thick. I mentioned a little bit earlier that the nasal bones are thin below and thick above. So it is the thickest at the point of the nasion. At this point, the nasal bones cannot be compressed. So lateral osteotomy should not be extending up to that level. So that's all about the bony vault of the external nose. Next, we'll talk about the second part of the external nose, which is the upper cartilaginous vault. Now, the upper cartilaginous vault, it consists of two parts. The major portion is formed by the upper lateral cartilages on both the side, and also a part of the cartilaginous septum also contributes to this. And these are enclosed in a common perichondrial sheet. So this is very important here. So these both upper lateral cartilage and part of this cartilaginous septum, they have a same embryological origin. So and they constitute a single cartilage unit. So they are not separate. They have a same perichondrial sheath. So that's what's forming the upper cartilaginous vault. Now, a very important term we need to know here is the K area, also known as the keystone area. And this is very, very important to know. If we look at the image over here, we can see that this is the nasal bone. This is the frontal process of the maxilla, and here we have the upper lateral cartilage, right? So the junction which is formed between the nasal bones, the upper lateral cartilage, and the septal cartilage, which you're not able to see in this image, and the perpendicular plate of the ethmoid, this junction is known as the keystone area because this is the center of support of the nasal roof. This is a very important area. This is giving you a central stabilizing support, and it is a structural anchor between the bony vault and the upper cartilaginous vault. So keystone area is a very important structure that we need to know. If this area gets weakened during the time of rhinoplasty, it will lead to the collapse of the dorsum of the nose. We spoke about the dorsum of the nose, which extends the ventral aspect of the nose, which extends from the nasion to the level of the tip. This dorsum will collapse if the keystone area has been weakened during the time of your surgery, and it can even result in saddle nose deformity. So it is very important for us to identify the keystone area. So you can see it is the junction of the nasal bones This is the nasal bone junction with the upper lateral cartilage here, and behind this would be your septal cartilage as well as the perpendicular plate of the ethmoid. So this is about keystone area. Now let's try to understand what are the different relations of the upper lateral cartilage, just like we did for the nasal bones. So laterally, the upper lateral cartilages, they are just short of the piriform edge of the maxilla, and the intervening gap between the piriform edge of the maxilla and the upper lateral cartilage, it gets filled with dense fibrous tissue, and this gap is known as the empty triangle. So that is a lateral relation of the upper lateral cartilage. Next, coming to superior relation. The superiorly, the upper margins, I already spoke about this, that the cephalic border or the upper margins of the upper lateral cartilage, they are united under the lower ends of the nasal bone and the frontal process of maxilla with the help of connective tissue. So in this region, if we look over here, the upper lateral cartilage actually, this is the lower edge of the nasal bone, and the upper lateral cartilage actually extends a little above the lower edge of the nasal bone. And the upper lateral cartilage can extend almost about 1 centimeter, and there is a fusion of the perichondrium and periosteum at this level. And this connection that we have over here, this the fusion of the perichondrium and the periosteum, this connection, this firm connection that is forming between the nasal bone and the upper lateral cartilage over here, this is the reason why it is able to, we are able to see the transmission of the motion of nasal bone to the upper lateral cartilage. So this region, the keystone area that you're seeing over here, this region, the upper lateral cartilage is extending a little further above the lower end of the nasal bone. Next, we have the inferior relation. So the caudal edge of the upper lateral cartilage, it is rolled outwards and upwards, forming a scroll-like region. Let me show you in a different image over here. Yeah, if you look at this the thing marked as A. So this is the upper lateral cartilage, and you can see that how it is curving over here. This curve that we are seeing over here, where we can see it is rolling outwards and upwards, this is forming a scroll, right? And this scroll is responsible for contributing to the widening of the dorsal area or the dorsum and the lateral wall. What is the importance of this scroll? It is necessary sometimes to excise these scrolls, especially if they are very prominent. They can end up forming a deformity which is known as polybeak deformity. So the thing marked A is the scroll which is formed by the upper lateral cartilage. Next, we have some angles that we need to know over here. So let's look at the image here to understand. This here is the septal cartilage, right? This is the perpendicular plate of ethmoid. So the angle which is formed at the junction of the dorsum. So this is the dorsal border and this is the caudal border of the septum. The angle which is formed in between these two, this angle over here, this is known as the anterior septal angle. Whereas, if we look at this angle over here, which is formed between the inferior border and the caudal border of the septal cartilage, this angle is called the posterior septal angle. These are all landmarks that you need to be very aware of. Next, we have another triangle. We learned about the empty triangle, which is formed between the upper lateral cartilage and the piriform edge of maxilla, which consists of dense fibrous tissue. Now we'll know about the weak triangle of Converse. What is the weak triangle of Converse? So this is actually a very small area that we will find. We just showed you the region of the anterior septal angle. So the area at the anterior septal angle where the upper lateral cartilage may separate slightly from the septal cartilage, that area has only loose fibroareolar tissue in between. If you look at the image over here, this yellow marked region, this is the weak triangle of Converse. So how do we define the weak triangle of Converse? It is a small weak area at the anterior septal angle where the upper lateral cartilage and separates a little bit from the septal cartilage, and it contains only loose fibroareolar tissue in between. Now, the importance of knowing this is because there is only loose fibroareolar tissue here, it does not have a proper firm cartilaginous support or a continuity of the cartilage. So, structurally, this is actually a weaker area compared to all the surrounding areas that is have. So, this weak triangle of Converse is actually a potential point of dorsum instability, collapse, and even deformity formation. So this is important to know, to be able to know which area exactly is this weak area which can lead to instability of the dorsum of the nose and collapse and deformity or saddle nose deformity formation. So after a cartilaginous hump excision is done, the lateral cartilages, they become discontinuous with each other. And this at this point, when it becomes discontinuous with each other, the stability of the upper lateral cartilages is maintained by their attachment to the nasal bones and the frontal process of maxilla. I told you how the upper border of the upper lateral cartilage in the region of the keystone area, it goes a little further above the lower edge of the nasal bone, about 1 centimeter, and the periosteum and perichondrium fuses over here. So this is forming a very strong support area, and this is also responsible for giving stability to the upper lateral cartilages. So this is about the upper cartilaginous vault, which is mainly composed of the upper lateral cartilages and a very small portion of the cartilaginous septum. And the key things the terms that we learned over here is the K area or the keystone area, the importance of that. We learned about the empty triangle, scroll, anterior septal angle, posterior septal angle, and the weak triangle of Converse. Next, we'll talk about the last part of the external nose, which is the lower cartilaginous vault. Now, the lower cartilaginous vault are formed by two things. So here we can see this structure over here. This is the lower lateral cartilage, also known as the alar cartilages. So we have one on each side of the nose, and then we have some smaller cartilages, which is known as the sesamoid cartilages. These two things together form the lower cartilaginous vault. Now, first, let's talk about the lower lateral cartilage. So, the lower lateral cartilage is actually a single piece of cartilage on each side, and it has three parts. It has the medial crus, it has the lateral crus, and then it has the dome in between the two crus. So, the medial crus, it lies immediately under the skin of the columella. So, we know the structure which is there at this level. This is the columella, and the medial crus, both of them, they join in the midline. They're attached to each other by fibrous tissue, and they also get attached to the lower end of the septum with the help of the membranous septum. So medial crus is lying right under the skin of columella. Then we have the dome. Now this dome is actually contributing to formation of the lobule and the tip of the nose. So the dome is basically the meeting point of the medial crus and the lateral crus of the alar cartilage. Then the third part that we have is the lateral crus, and this lateral crus is about 1 millimeter in thickness. The upper edge of it is also forming a scroll. So I had shown you before how the upper lateral cartilage, the lower border, forms a scroll area which is marked by A. If you look at B, this is the lower lateral cartilage, and you can see how the upper edge of it is curving again, and it overlaps with the lower edge of the upper lateral cartilage, and that is also forming a scroll. So we have two cartilages forming scrolls over here. So and you can see in the image over here that the scrolls of both the upper and lower lateral cartilage, they are actually in opposite direction and they glide against each other. So that's about the lateral crus. Lastly, the caudal margin of the lateral crus. This has a convex edge, And the maximum convexity of the lateral crust is very close to the alar margin near the middle part of it. From this point of maximum convexity, the caudal edge of the lateral crust advances further horizontally and it meets the medial crust and helps to form a small triangular area of soft tissue in front of the nares, which is known as the soft triangle. So, what is a soft triangle? If you see the yellow marked area over here, the soft triangle is basically a very small triangular soft area which is located between the tip of the nose between the tip of the nose and the nostril edge. This area actually does not have any underlying cartilage inside it. So, therefore, it has been called as the soft triangle. What does it contain? It contains the external and the vestibular skin with very scanty intervening areolar tissue. So this is the soft triangle. Now, what is the importance of knowing about the soft triangle? Now, these soft triangles, the facets are actually very prominent and pleasing in females. These are actually regarded as the signs of beauty in a feminine nose. So you have to know the location of it, because if you give any incision in this area, it can actually result in a deformity. So, this is the importance of knowing about the soft triangle. You know that we spoke about the weak triangle of Converse in relation to the upper lateral cartilage. In relation to the lower lateral cartilage, we have the soft triangle. Now, the lower lateral cartilage, it contributes to the formation of two things. It contributes to the formation of the lobule and it also forms the columella. So, if we look over here, this is the alar cartilage, this is the lateral crust, this is the dome, and then this is the medial crust. Again, this is the medial crust, this is the dome, and the lateral crust. So, you can see how the lobule and the columella is being contributed by the lower lateral cartilage. First, let's talk about the lobule. So the lobule, as you can see, is formed by the lateral crura and the dome of the lower lateral cartilage. So if you look here, this is the lobular region. So you can see how a part of the dome and a part of the lateral crura of the lower lateral cartilage is forming the lobule. So the tip is formed by the two domes. This is the tip of the lobule, and it is the most anterior part of the lobule. So what is the tip? Tip is actually the most anterior part of the lobule. And if you had to talk about the boundaries of lobule, the lobule is bounded superiorly by the supra-tip depression and laterally by the depression between lateral crus and alar prominence. And if you try to hold your own nose, if you try to hold the lobule, you'll see that the lobule is actually very flexible. So the lower cartilaginous part is actually a separate part of the nose and it does not have any connection with other structures except for an aponeurosis, which is formed by the continuity of the fibrous envelope that is investing the upper and the lower lateral cartilages. So therefore, the lobule, as you can see, because it does not have any other connection to the other structures of the nose, it is only connected by a aponeurosis, the lobule is able to be moved freely mobile upwards, downwards, and from side to side. So if you can touch your lobule right now and you try to move it up, down, and side to side, you'll be able to move it because there is no proper connection between the lobule and the other structures of the nose. So that's about the lobule. Next, we have the columella. Now, what is the columella? If we look at the image over here, so the columella is actually extending from the in between the lip and the tip of the nose. So this is the columella, and the shape and size of the shape of the columella, especially, it will depend on the size and contour of the medial crura of the lower lateral cartilage. If we look over here, you can see that this is the medial crura, right? Now the medial crura, they meet with each other in the midline, and this whole region is forming the columella. And this, so the columella in itself, they can be divided into three parts. It has the upper lobular part, then it has the middle narrow part, and then again a wider lower or the basal part. So this is the divisions of the columella. And you know that they consist of the two medial crura with intervening areolar tissue and covered with a very thin layer of skin in between. So this medial crura, you can see if the medial crura are excessive in length or if it is too short, then what it will do is it will end up either if it is the medial crura are too long or long in length, you will see that the nose will be over projected. Or if the medial crura are too short in length, in that case, the tip will be very depressed. So that's why this is the importance of knowing what columella is formed by. It's formed by the two medial crura. And if we see in the image over here, the two medial crura, they are actually meeting at an angle with each other in the midline. And the angle over here formed is about 30 degree. This angle that is formed over here, where the medial crura are diverging outwards, this is responsible for formation of the width of the tip. Normally, it is about 30 degree. If it goes more than 30 degree, it can lead to increase in the width of the tip of the nose. Posteriorly, as you can see, the free end of the medial crura, they again diverge away from each other and they receive the posterior septal angle over here. So this is about the lobule as well as the columella, both of which are being formed by the alar cartilages. Next, we have something which is known as the tripod concept, which was given by Anderson in 1969. Now, what is tripod concept? So, Anderson actually, what he did was he compared the lower lateral cartilage that we know. The lower lateral cartilage was compared to a tripod actually, which means the relatively long leg of the lateral crura and one short leg of the medial crura joined to each other. And this tripod that you're seeing over here, it is supported by part of the upper lateral cartilage, part of the caudal border of the septal cartilage, the soft tissue at the base of the columella, as well as the membranous septum. The medial crura, they end up resting on fatty tissue at the base of the columella. So this fatty tissue on which the medial crura is resting, this fat can actually atrophy after any kind of trauma like surgical trauma or even with physiological absorption in old age. And that can lead to the drooping of the nasal tip. So that's about a little bit about the lower cartilaginous vault and it's how it's forming the lobule and the columella and the tripod concept, which is basically Anderson saying that he's compared the lower lateral cartilage to a tripod and how the tripod is supported by 4 different structures over here. So that's all about the tripod concept. Next, there is another concept that we need to know, which is about the domes. So, Bernstein in 1974, he gave a very detailed description of dome. He talked about 3 different types of dome. Now, we spoke about how the medial crura and the lateral crura join in the middle, and the junction is what is known as the dome. So, here we have 3 domes over here: anatomical domes, clinical dome, and a surgical dome. Now, what is the anatomical dome? Anatomical dome is the actual cartilage bend that we are seeing at the junction of the medial and the lateral crura. This is the true anatomical bend. This is the actual cartilage bend that is anatomically present. Next, clinical dome is what the clinicians are seeing as a tip defining area. This clinical dome, it is demarcated by the deepest part of the cavity inside the vestibule, which is formed by the 2 medial crura. This clinical dome is more obvious in a thin-skinned nose and in females where the tip of the nose is very pointed. And some of the times the clinical and the anatomical dome can be very identical to each other. So clinical dome is what the clinicians are seeing as a tip defining area. Third is we have a surgical dome. This is the dome which is reported at the time of surgery when the definition of dome is lacking preoperatively. So surgical dome is basically what the surgeon is using during the time of operation. So these are the 3 domes. Anatomical dome is the actual cartilage bend. The clinical dome is what clinicians are seeing as a tip defining area. And the surgical dome what the surgeon sees during the time of operation. Now, we have learnt about the osteocartilaginous framework of the external nose. Now, Above this, we also have some other stuff. We have the soft tissue covering, we have muscles of the nose, we have blood supply and nerve supply of the nose. So, we need to have a very intricate knowledge of these things as well. So, let's talk a little bit about those. So, coming to the soft tissue covering, so we know that we have a layer of skin over the nose. This nasal skin is actually not uniform everywhere. This nasal skin is the thickest at the level of the Nasion and it is thin at the level of the Rhinion. And then again, it thickens above the tip in the supra-tip area. So you can see how the skin thickness varies all over the nose. Skin over the lower part of the nose actually much thicker and more firmly attached to the alar cartilages than the skin of the upper part of the nose. And the skin over the nasal bone and the upper lateral cartilage, if you try to touch it, you'll be able to see that it is actually mobile. And in the skin of the alar, we have a lot of sebaceous glands. So if you touch your alar region, you'll see usually that region is very oily. The reason for that is a lot of sebaceous glands are concentrated in the skin of the alar region. So these are all little tidbits that you need to know about the soft tissue covering. Next, moving on to muscle of the nose, we'll talk about 4 muscles over here. First, we have the Procerus muscle. Now, let's look at the image over here. So, first muscle is the Procerus. This Procerus muscle, it arises in the from the upper part of the upper lateral cartilage and the nasal bone. And as you can see, it gets inserted into the skin of the root of the nose. Now, this Procerus, when it is cut from the dorsum, these fibers can contract downwards and tend to fill the nasofrontal angle postoperatively. If it does that, it will lead to formation of a Grecian profile because the nasofrontal angle will get obliterated. So that's the importance of knowing the Procerus, where it arises, where it goes. Next, we have the compressor naris, also known as the transverse part of the naris. So, if you look at the image over here, the yellow marked muscle, this is the nasalis muscle. It has 2 parts. So, one of the part is the compressor naris, which is the transverse part, and the other part is the dilator naris, which is the alar part of the nasalis. So, the compressor naris that arises from the maxilla on each side and it gets inserted into the dorsum of the nose in the lower part in the aponeurosis. And mobilization of the skin in the lower part of the dorsum of the nose liberates this muscle, resulting in a slight supratip depression. Now, this dilator naris, also known as the alar part of the nasalis muscle, this also arises from maxilla, but it arises over the lateral incisor tooth region and it gets inserted into the lateral part of the crus. So these are the 2 nasalis muscle. Lastly, we have the depressor septi muscle. Now the depressor septi muscle, it arises from the incisive fossa. It arises from the incisive fossa of the maxilla and it gets inserted into the caudal end of the septum and part of the alar base. This muscle, as you can see, lies deep to the orbicularis oris muscle, and the importance of this muscle is that it causes a drooping of the nasal tip during smiling and it makes the membranous septum tense during deep inspiration. This is the muscle that there's a very important question that you need to know, which is the muscle which gets sectioned when you give a transfixian incision in rhinoplasty. The muscle that gets sectioned is the depressor septi muscle. It is not procerus, it is not nasalis, it is the depressor septi muscle that gets sectioned. So these are the different muscles of the external nose that you need to know. Next, moving on to the blood supply. So the blood supply, which is the arteries and veins of the external nose, they are all located superficially in the soft tissue. So first, let's talk about the arteries. So we have branches of the facial artery. So this here is the facial artery. You can see how this is giving branch to angular artery and the superior labial artery. Now the angular artery itself goes and it gives branch the lateral nasal artery. Whereas the superior labial artery, it is giving 2 branches, the columella branch and the septal branch. These are all the branches of the facial artery. Next, we have the ophthalmic artery, which gives rise to your dorsal nasal artery and it also gives rise to the anterior ethmoidal artery. And the anterior ethmoidal artery itself gives rise to the external nasal branch. And lastly, we have the infraorbital artery. So, this is the arterial supply of the external nose. Coming to veins, the most of the venous drainage occurs via the angular veins and the ophthalmic veins. So, the importance of knowing the level at which the arteries and the veins lie is that to know your plane of dissection when you're mobilizing the tissue. So, in your rhinoplasty, when you're mobilizing the soft tissue after giving your opening incisions, the plane of dissection to mobilize the soft tissue has to be closer to the bony or the cartilaginous framework so that we avoid any kind of injury to these muscles, to these superficial vessels. Because if we cause an injury here, it can cause unnecessary bleeding and even button holding of the skin. So, this is about the blood supply of the nose. Next, coming to the sensory nerve supply. So, the nose is supplied primarily by the ophthalmic and the maxillary divisions of the fifth nerve. Let's look at the images over here. We have the supratrochlear nerve. We have the supratrochlear nerve and the infratrochlear nerve. These are both branches of the ophthalmic nerve, and you can see how they are supplying the skin of the nasal root, the nasal bridge, and upper portion of the side wall of the nose. Next, we have the infraorbital nerve, which is a branch of the maxillary nerve, and this is supplying the remaining of the nasal side wall. Then we have the external nasal nerve, which is a branch of the anterior ethmoidal nerve, and this exits between the nasal bone and the upper lateral cartilage, and it supplies the skin over the dorsum and the nasal tip. Lastly, we have a few terminal filaments of the palatine nerves, which supplies the skin at the base of the columella. Now, this is our sensory nerve supply. Again, this is important because before you start your surgery, you will be giving some infiltration to the nerves in these areas. So, this is important for you to know the landmarks over here. Lastly, we'll talk about the anatomy of the septum and a little bit about the nasal valves. I have a separate video where I speak in depth about the anatomy of the septum, and I also have a separate note on anatomy of the internal nose where I discuss the different nasal valves as well. This is just for a recap of the same thing. For details, you can check out my videos over there. So, coming to anatomy of the septum, if we look at the osteocartilaginous part of the septum, the cartilage is mainly formed by the septal cartilage. And then let's talk about the bony part. So, the major contribution of the bony part is from the perpendicular plate of ethmoid as well as the vomer, as you can see. But there are some minor contributions as well, like we have the crest of the nasal bone, the nasal spine of the frontal bone. Then we have the anterior nasal spine of the maxilla. We have the crest of the maxilla, we have crest of palatine bone, and the rostrum of the sphenoid. All of these bones have a minor contribution to forming the bony part of the septum. So, the septum, if we had to talk about, actually has three parts. We have the columellar septum, we have the membranous septum, and then we have the septum proper. And the septum proper itself has the osteo and the cartilaginous part. So here we have the columellar septum, the membranous septum, and the rest of it is forming the osteocartilaginous part of the septum. And when we talk about the bony part, we don't just talk about the perpendicular plate of ethmoid and vomer, because there are a lot of minor contributions from all these bones as well. Next is external nasal valve and internal nasal valve. So these are again important because they are important for the nasal obstruction. So if we look at the external nasal valve boundaries, let's look at the image over here. Laterally, we have the alar rim, which is formed by the lateral crust of the lower lateral cartilage, the sesamoid complex, and fibrofatty tissue. Medially, we have the cartilaginous nasal septum, and on the inferiorly or in the floor, we have the nasal sill. This is the external nasal valve boundary. But the one which is more important to us is the internal nasal valve, because this is the region responsible for, is the least cross-sectional area of the nose. So any deformity or collapse of valve in this area can lead to a functional obstruction of the nose. What are the boundaries of this? The boundaries are, medially it is formed by the septum. Laterally, we have the caudal edge of the upper lateral cartilage, and the head of the inferior turbinate, and inferiorly we have the nasal floor. So if you look at the image over here, this is where the internal nasal valve lies. This is where the external nasal valve lies. To learn more about this, you can check out my video on anatomy of internal nose. So that's all about the surgical anatomy of nose, a little bit in brief that you need to know before we dive into rhinoplasty. I hope you have understood this. If you have any doubts regarding this, please note them down in the comment section and I'll get back to you. Thank you.